Statins have been called wonder drugs. They're a class of pharmaceutical that helps lower cholesterol to reduce the risk of heart attack and stroke. They are taken every day by thousands upon thousands of Canadians. But they are not without their issues. Here for more, two heavy hitters in the field. Dr. Haider Warraich, a cardiologist at the Duke University Medical Center in Durham, North Carolina, and author of the forthcoming book, State of the Heart, exploring the history, science, and future of cardiac disease. And Dr. Paul O, Medical Director of the Toronto Rehabilitation Institute and Chair of the Good Life Fitness Center of Excellence in Cardiovascular Rehabilitation and Prevention. That's at the Peter Munk Cardiac Center, both part of the University Health Network, and we are delighted to welcome you two to our studio tonight for a conversation about something that a lot of people know a little bit about, and we hope we're going to learn a lot more about it over the next 25 minutes or so. Haider, cholesterol connected to heart disease, how?
So this is a science that has evolved over several decades, but I think that this is one of the few things that a lot of people agree on, is that cholesterol seems to be fairly directly linked to the risk of heart disease. This really started off with work that was done by Ansel Keys in the 7-country study, but has really been replicated again and again. Cholesterol is not the only risk factor for heart disease, but it does seem to be one of the few that we can, in fact, modify with both diet, exercise, but also with medications that you've already mentioned, which we're talking about, statins.
Except, Paul, I keep hearing about good cholesterol and bad cholesterol, so help us understand that distinction.
Sure. The epidemiology talks about distinguishing LDL, or low-density, lousy cholesterol, and healthy, high-density, HDL cholesterol. And roughly the epidemiology would say the higher your LDL, the worse your risk for heart disease. In counterbalance, the higher your HDL, the more protection that you have. So both are very important. The focus of treatments in recent years has been on lowering that LDL cholesterol primarily.
And what function does cholesterol actually serve in our bodies?
It's all over the place. It's in every one of our cell membranes, for instance. It's part of our nervous system. It's part of bile acids. It's part of hormones. The discussion we have with our patients is because it's so ubiquitous and comprising cell membranes, we said if we don't have cholesterol, next time you have a shower, you'll just melt away.
Is that all right? So it's a good thing we have it.
We need some of it, absolutely.
Okay. I want to read an excerpt from your book just to set up the next question here. So Sheldon, if you would, bring up the graphic and I'll read along for those listening in on podcast. Statins reduce the risk of heart attacks, strokes, the need for cardiac procedures, and perhaps most importantly, deaths from heart disease in almost every patient group. Men and women, diabetics and non-diabetics, young and old, smokers and non-smokers, people with low and high cholesterol, low and high blood pressure, and those with and without prior heart disease. On average, in high-risk patients, statins achieve an absolute reduction in the rate of adverse events by 10%, on top of everything else one can do to reduce the risk of adverse cardiac events. Okay, that's only part of the story, because in your book, State of the Heart, you go on to say, few medications have been as controversial as cholesterol-lowering statin medications. No day goes by without these medications, the most commonly prescribed drugs in the United States, being simultaneously declared our saviors from all sickness or the determinant of all of our deficiencies. And like every other compelling story, that of cholesterol has its fair share of backstabbers, fearmongers, snake oil salesmen, and of course, superheroes. Okay, so much to unpack here. Statins, what are they to begin with?
So statins are medications that lower what has been called lousy cholesterol in the body. And they're, I would say, perhaps the best studied medications in human history. The reason is because we have been able, there's so many medications that have there's so many types of statins that have all undergone rigorous randomized control trials that have really shown that that they reduce risk really across all groups. Now that risk reduction has everything to do with where your risk starts off.
Okay.
So if you're at low risk to begin with, the benefits that you may get from a statin are not going to be as high as opposed to if you start off with higher risk.
Sure.
So even though it does do benefit in almost all groups, that benefit can vary depending on where you are on that initial sort of risk spectrum, so to speak. statins are very controversial, and part of the reason why they're controversial is because so many people have some type of indication to be on them, because heart disease, as you know, is the #1 killer of human beings in almost every country around the world. As even in developing countries now, it is emerging as a top killer. And even though I would say, and I think everyone agrees on this, that the first things that we can do to reduce our risk of heart disease is by lifestyle interventions such as good diet and exercise, we know that there's still a significant number of people who have a very high residual risk of heart disease even after those interventions. So, and statins are really a key piece that we have that can help modify that risks. There are a lot of non-modifiable risks of heart disease, but one of the modifiable risks is the level of LDL cholesterol in your blood, and statins do seem to help with that.
Okay, hold off the story at that point there. Pick up the story as to why statins have been so widely prescribed across so many different groups, across so many different countries.
I think a snowball of evidence. When the cholesterol hypotheses came out a few decades ago, people recognized that lowering cholesterol was probably a good idea. There was an association with high cholesterol and heart disease. But prior to the statin era, it was actually difficult to get cholesterol down. We talked about diet, exercise, and probably a minority of people will actually follow that through to the full extent possible. The early drugs that were available were these nasty things, resins or sand that you had to mix in water or juice and drink, and it was very poorly tolerated. So cholesterol was really the domain of some specialists that really focused on cholesterol. When statins came out as a single pill that could lower cholesterol by 30 or 40 or 50% even, it became very easy to do. And then a series of large randomized trials that looked at people first with heart conditions, and seeing a dramatic effect on lowering heart attack, stroke, or death was evident. So statins really started to gain momentum in the medical community as a real promising therapy to change the future. It was coupled, of course, with pretty aggressive marketing all over the place, and certainly in the medical community, that made these things rather attractive.
Can I pick up on that angle of the story? Because, I don't want to say just the conspiracy theorists, but there'll be skeptical people among us who will say the pharmaceutical companies, the doctors, marketing have all combined in a perfect storm to make millions of us believe that life cannot go on without these things. And that's why they are being, in the view of some, overprescribed to such an extent. What's your view on that?
Well, I think with all therapies or all aspects of life, we have to be kind of thoughtful in choosing the right therapies for the right person at the right time. And in that respect, when we talk, and I think we agree on people living with heart conditions or stroke or evidence of vascular disease somewhere in their body, that there's very little controversy that lowering cholesterol is a good idea in those kinds of individuals. The combination of all of these therapies, including statin drugs or other medications, is probably the right way in lowering risk and helping this person live long and live well. Where the controversy starts is when people fall outside of those trials, where sometimes the evidence creeps into populations where the benefits may not be as strong, or where people experience difficulties with these medications. And therefore, it seems like there's a tension between what doctors or companies might be promoting and the patients might be experiencing.
There's a tension as well between brand names and generics. How does that work itself out in this drama?
So I would say that I agree with everything Dr. O has said, and I think at this point, one of the good things and one of the things that allows me to be actually very comfortable with supporting statins for patients who are at high risk for heart disease is that all major statins are now generic. So they're actually very low cost, both to the health system but also to the individual patient. And at this point, to me, I share a great deal of skepticism about any type of intervention, and I think as a physician, we need to be really there to protect our patients, really from everything, including the interventions that we make ourselves. But the most compelling case for statins really comes from the science at this point, and that science is pretty robust. So even though I think a healthy deal of skepticism is really something that we need to incorporate in our practice, I do think that the most compelling evidence for why statins, I think the medical community in general supports at this point in time has really come from the decades of randomized clinical trials that have been performed for these medications. Having said that, I think it would be a disservice if we do not say that like every other therapy, statins do have risks, and they're documented.
Well, let's talk about those now. Side effects, like what?
So if you look in, so the interesting story about statins is that you have a lot of data from randomized trials in which patients either get statins or placebo, and they don't know what they're taking, nor do the physicians who are giving them. And if you look in those trials, there are a lot of risks that have come about. One of them is that statins do accelerate the development of diabetes in some patients who are at risk for developing diabetes in general.
So what percentage would that be of all the people being treated on statins?
It's a very, very small percentage, but again, this is patients who are at risk for developing diabetes regardless,
No,
and it just accelerates.
Small means 1% or 10%? I mean, those are both small numbers.
It's in the single digits.
Single digits, okay.
It's a very small, and even in those patients, even those who sort of tip over and develop diabetes with statins, the benefit of statins is still greater than in patients who are at high risk than those not taking it.
Paul, what about, I mean, I hear about muscle pain, I hear about fatigue, those kinds of things. How prevalent is that?
Absolutely, and it depends on how you look at those numbers. In the trials that my colleague is talking about, up to 30 or 40% of people in clinical studies report muscle aches and pains. Now, distinguishing that signal from what's actually medication related versus what's related to life, that's the trick of it. Because when we ask 60-year-olds, do you have aches and pains? Most people will say, yes, indeed, I do. So the difference between placebo and drug is probably in a few percentage range of actual muscle aches and pains. And then there's even fewer that have more serious effects like muscle inflammation or this really unusual condition called rhabdomyolysis, actual muscle breakdown. But for those who are affected by muscle aches and pains, it can be such a serious issue and a debilitating issue on a day-to-day basis that we really need to pay attention and find alternatives.
So what do you do if you need statins, but you get this kind of adverse reaction? Should you go off them or tough it out, or what do you do?
So I think recognize it, first of all, and have that conversation with your healthcare practitioner. If it's truly statin-related, then it tends to be there throughout the day, affect big muscle groups, neck, shoulder, back, legs, hard to get up out of a chair, hard to walk upstairs. So if it's got that character, then it may be statin related, as opposed to something that comes and goes, that probably not. With your physician, healthcare practitioner, you may have a conversation about, is this in fact related to drug? Can I have a drug holiday for a couple of weeks to see if it gets better? But then commit to going back on to see if it gets worse. If it's still there, can we change the dose? Can we change from one to another of a statin family, or think about alternate therapies as well?
And just out of curiosity, how many times a day would you be taking these if you need to take them?
It's a single dose once per day, typically. But for those that are actually having some difficulties with some of the newer, longer-acting ones, you may go to every other day, for instance. So very minimal dose, but still having profound effects on cholesterol.
Got it. You mentioned placebos a moment ago, and I want to follow up on that aspect of the story, because when you're doing clinical trials, of course, some people are getting the real deal, and some people are getting a sugar pill or whatever it is you put in there, a placebo, no active ingredient. And to that end, you write in your book the following: the reason patients receiving statins in trials don't demonstrate greater aches and pains isn't because they don't feel those symptoms, it is because a similar number feel symptoms receiving placebo. So if that's the case, how do you know?
So, I mean, I think that the statin story really reveals both, what our expectations of medical therapy really are. And one of those aspects is the placebo effect, in which we perceive a potential benefit from just the act of taking a medication. Now, what people are experiencing with statins increasingly frequently is something called the nocebo effect, which is in some ways you can think about as the evil cousin of the placebo effect.
Nocebo?
Nocebo.
N-O-C-E-B-O.
N-O-C-E-B-O, in which patients experience symptoms because they're fearful of harm from the medication or from the therapy or whatever intervention. If you look in trials, and this is really captured very well in a trial called ASCOT, which was published in The Lancet. So this was a blinded trial in which patients did not know whether they were taking placebo or whether they were taking a statin. Now, as long as the patients did not know what they were taking, the rate of muscle pains were similar in patients taking placebo versus statins. But during the trial, it became very clear that withholding statins from patients was actually a disservice, that was actually an unethical thing to do. So they unblinded the trial, in which now patients suddenly knew whether they had been taking placebo or whether they had been taking statin.
Wouldn't that render the results Like not reliable?
In fact, it actually led to a very interesting result in which now that the patients knew what they were taking, now the rate of muscle aches when the patients who were taking statins actually went much higher than patients who were taking placebo, even though they had been equal before they knew what they were taking. None of this is to minimize symptoms that patients are taking, symptoms of statins. None of this is to minimize that the patient's experience is not important. In fact, I would say it is the most important thing. We shouldn't be asking patients to tough it out, but we should be having thoughtful discussions about what we've seen is the true prevalence of these symptoms and what are the benefits, and then balancing them out with the expected what the expected outcome would the patient like.
Well, Paul, I need your take on this, though. Why would people who are taking a sugar pill be so susceptible to experiencing the same kind of pain as those who are on the real thing?
Sure. So a couple of reasons there. One, if we're looking at very common phenomenon, such as an ache and a pain, and we're asking people repeatedly, are you having aches and pains? Then that does prompt a positive response. And that's seen in trials where, for instance, if you look at side effects from various medications, you'll find cold and flu, for instance, on the list of side effects, simply because they do occur in the environment. But I would echo that notion that there is a real phenomenon, though, of people having real muscle pains, aches, that are medication related, that limit the ability to take these drugs, and that actually do impair quality of life.
That is odd, though, isn't it? It is odd that people would be experiencing these symptoms just with a sugar pill.
But this actually goes to a problem that I think is much bigger, and that is that right now, with how we receive information changing, there is a very widely prevalent view about statins that is being spread by a number of people through mostly the internet, in which a lot of patients, even before they ever take a statin, have already heard that that statins cause muscle aches and pains. So with that amount of misinformation spreading, again, and that has to do with the magnitude of the effect. This is not to say that statins don't cause those symptoms in some patients.
But they're prepped to feel it even before.
But they're prepped to feel it even more so. And one of the things that I've seen so many patients, before they take a single pill, they are already primed to experience those symptoms because they've heard so many bad things about statins that are out of proportion to the actual risks of the medication.
Sure. Let's, obviously all of this is a balance, Paul, but if patients are experiencing significant pain, so much so that it's affecting their ability to stay fit, do all the exercises and so on that would keep them fit, how do you balance the risk of too much harmful cholesterol in your system with the lack of fitness that you're now experiencing in order to stay healthy? I mean, you're, I guess, juggling a few balls here at once.
Yeah, absolutely. And this is where we get to the individual level and finding what's going to work best in that situation. So if a high dose of cholesterol medication, which is the typical practice these days, is intolerable, then let's look at using lower doses of a statin medication, maybe combine it with another medicine that doesn't have those effects, but still seek to reduce the cholesterol as much as possible for that person. That makes those other things tolerable, because we do believe that exercising 5 days a week and eating well on a daily basis, those also have really positive impacts on future heart risk. So take some of this, and that's the best we'll get to in this situation, and that's probably the best we'll do, and that's a good recipe for that individual.
The best idea is still to pick your parents well.
There is always that phenomenon, choose wisely, and people always wonder, why me? Why is that? Yeah.
I kind of ask, why not me? Everybody's got something. Haider, let's finish up on this. How has having the statin debate as part of the public discourse helped or complicated how you deal with your patients on this issue?
I think every time we can have the public and people more engaged in their health, I think it's a win-win. I think if people are thinking about statins, what that means is they're also thinking about their health. If people's fear of statins means that they're going to exercise more and they're going to watch their diets, that's a win-win for all of us. But at the same time, we also need to make sure that this debate is not hijacked by people whose interests have nothing to do with the patient's health, whose interest has to do with selling alternative products or selling their own hypothesis or driving traffic to their website because they're attracting people who are scared and who don't want to experience side effects or who want to be sick. So I think that this is a really interesting area where we're looking at how patients are receiving information is changing. But every time I have a patient who's more engaged in their health, whether that is about statins, whether that is an opportunity for me to really work with them and think about ways that we can work together to get them the best possible outcome.
Gentlemen, that's our time. I promised everybody at the beginning that we would know a lot more about statins by the time we got to the end, and I would say mission accomplished. Well done.
Thank you very much.
That's Paul Lowe, Medical Director and the Good Life Fitness Chair, Cardiovascular Disease and Rehabilitation at the Toronto Rehab Institute and the Peter Munk Cardiac Center, all part of the UHN, and Haider Warraich, cardiologist, Duke University Medical Center, and the author, if you want to know more, of the book State of the Heart, Exploring the History, Science, and Future of Cardiac Disease. Two of the longest titles of any guests we've had on this show, but they've got lots of knowledge behind those titles. Thanks, gentlemen, very much.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario, helping businesses stay on the right side of change with strategic thinking, insightful decisions, and business leadership. Are you on the right side of change? Ask an Ontario CPA.